Okay, it's almost finished, so you should be good to go.
Thank you. All right. Hello, everybody. Welcome to our second round of regional report out calls. This is the Northeast Regional Report Out call, which will happen this time every Tuesday. It's 2:00 Central Standard Time. That's when we go live. You can also sign up to get this call plus the dashboard that we're about to review sent to your email if you go to covid.ks.gov/report-outs. That's covid.ks.gov/report-outs. You can also email us questions or comments to ksregionalreport@gmail.com. That's ksregionalreport@gmail.com. We got some good comments last week. We're going to change the format just a little bit. I'm going to review the dashboard that the Hospital Association so generously puts together for us. And then I'll ask our friends from Public Health and from the hospital to provide color. We'll get a boots on the ground report, and then we'll hear a little bit about transfers and how that process works and the data that's around that from Dr. Watson and Jesse here from Cheyenne Mountain Software, who handle the Mission Control app. So we won't have a lot of details on vaccines on this call. That will come in calls following, though that has been a very encouraging step this week, I know, for people that are on the front lines to be beginning that process. And I will also tell you that if you are interested in getting tested and need to find a site, there's a website called gogettested.com/Kansas. Gogettested.com/Kansas can tell you where things are. So here we are. We're in the Northeast region. Let me share my screen so we can take a look and review the dashboard here today. All right. Can you guys see the dashboard here? Yeah. Okay. So this is the dashboard to be emailed out with this call. It's also available on the website. 21 hospitals in the Northeast region here, 100% reporting in. I like to move over. We know, and as Sarah so aptly coined, it comes down to staff, space, or stuff. Staff has been the main issue, so we're asking that question every week. A third of the hospitals right now in this region are anticipating staffing shortages this week. You can get a sense of the COVID hospitalized census there in your region. And then we move over to ICU beds and ventilators. And I like to look at this one right here, the percentage of adult staffed ICU beds. Obviously an ICU bed that's not staffed is just a bed. So this is the people with the expertise trained to be able to do it in the right place. We have 23% capacity in your region. Now this is yesterday's numbers. We get a snapshot in time. On this, it's very dynamic. The situation can move one way or another, but 27 of the 115 total adult staff beds were available. Then we move down and you can see what's going on with the new cases in this region. We're fortunately not climbing every week as we were there in the beginning of November, and have hit a little plateau in this region. I think everybody's got their fingers crossed that it either stay here or go down versus seeing a post-holiday bump. But you can see that, somewhere between 2,900 and 3,500 the last 2 to 3 weeks here in this region. On the second page, you'll be able to see by county, the percentage of the population of each county is tested positive. And then over here, here's the census of the ICU beds, what's available, how many are COVID patients and non-COVID. And I just want to remind people, and you'll hear this theme through the call, that what is going on in our situation impacts people that need ICU treatment that have nothing to do with COVID in these hospitals. So this dashboard, like I said, is sent out to you. What I'd like to do now is pass it over to Jen. And some of the feedback we got on that email was if everybody could just introduce themselves before they start talking to make sure people know. But Jen, if you could introduce yourself and give us a little color from the public health side.
Sure. I'm Jen McDonald. I'm with the Lawrence Douglas County Public Health Department. I'm the epidemiology supervisor. So I supervise all the disease investigations in the county. And basically what we're seeing right now is fairly good behavior, I guess would be the way to describe it. People are wearing their masks, they're keeping their social distance, and that's helping to keep our numbers under control. So it's really encouraging right now. We've got this light of hope with this vaccine. So we're really hoping that this is going to be good momentum to get us through the holiday season. And we've been very lucky because we have really good partners that work with us. We're working very closely with the surrounding counties. KDHE has been absolutely phenomenal guiding us through this, and it's really showing. There's a lot of confidence in what we're doing, and I think it's really telling.
Thank you. And a really general theme that you'll hear is that what we're doing individually is impacting the community, the small choices we make as individuals. And it's good to see people doing that. And it all impacts really the state as people move, as we hear how they move through the hospital system and all that, and the strain that we put on that group. So if people can continue to do what they're doing individually, it'll make a big difference. So thank you. Anything else you want to add, Jen?
I think that the one thing that we would also like to say on just our personal county view is that we have found that not only is the behavior being helpful in maintaining our caseload level, but also like the mandates that we had in place to make that happen were also really impactful in keeping control over things. So our kids could go back to school, so that we could have the gating criteria is low enough. So we're really excited to see how this is going to help in this next semester, being able to have the kids in school more. That's really important. So we're really excited about this.
Absolutely. Thank you for that. And on vaccines, and like I said earlier, we won't spend a lot of time on vaccines on this, but just as people can understand. So as they rolled out this week, there is a time frame before people are immunized. With the Pfizer vaccine, you take the first shot, then it's a 21-day period before you can take the second shot, and then it's a 2-week period before you're considered immunized. And I think on the Moderna shot, it's actually a 4-week period between shots, which is still a miracle that we have a vaccine this early and that's rolling out. But the vaccine rollout really won't start to impact numbers or things for another month and a half or so. And just want to make sure we put that out there for everybody. So Jen, thank you for that update.
Yeah, I think it's also really important to note that these vaccines are such a point of hope for everybody in the public health realm right now. And that it's that thing that's keeping us going so that we have the energy to keep helping people.
Yeah.
I think a lot of people think with vaccines, it's a whole different conversation. And the true moment of this vaccine is that this is that shining moment of hope for our healthcare workers to be able to get up to go to take care of people. So it's really important for us.
Thank you. I've heard it called literally an injection of hope.
Yeah.
The first tool that is offensive in this fight against COVID-19 gives everybody a lot of hope. But it means we're in this window where we really got to stay vigilant in our individual choices that impact the community so that as the vaccine rolls out, then we can be in better shape. Sarah, let me pitch it over to you. If you can introduce yourself and give us some perspective from the hospital situation, introduce your special guest.
Sure, thanks, John. So my name is Sarah Gideon. I work as the director of the Health Innovation Network of Kansas. Day-to-day basis, I work with 16 hospitals within the Northeast region. And for this call, I'm representing 23 hospitals within our area. And so I wanted to just highlight a couple of quick things for you today before I turn it over to my friend and guest, Laura Auberly. First and foremost is, regardless of the numbers that we hear, if you need emergent care, please seek it. If you need care, please call your doctor, please call your local hospital. We are there to take care of you. So even in the midst of crisis, we are here for you. Secondly, we have seen the vaccine start to roll out in our region to our healthcare providers. And the phrase that I really liked was the tiny vials of hope that people were seeing. So it's caused a real resurgence in energy and excitement for our healthcare workers, our nurses, doctors, lab techs, anyone in the facilities that are taking care of your loved ones, whether it's with COVID or without. One thing too, John, that I heard on the South Central call is that I want to remind people is that this first few months of vaccination doesn't give us all widespread immunity. We have several long months ahead of us, and collectively we can do this together. We can continue to follow our public health protocols that Jen was talking about with masking, washing hands, maintaining social distance, and in these next few weeks, really trying to limit the number of households that are mingling with each other. We love to go out on New Year's Eve. Let's not do that this year. Let's stay home and stay safe and keep our family members safe. You went over our dashboard, and so something I saw when I looked at this week's dashboard and compared it to last week's is Last week, we had 6 hospitals that were reporting critical staffing issues. This week, we have 7. So we're still continuing to see staffing to be an issue. And Laura's going to talk a little bit to that in her presentation. Last week, we had 35 adult ICU beds available. This week, we have 27. So we're seeing some changes there, but something that we have to keep in mind is those aren't all COVID patients. We actually saw an increase last week from 40% were non-COVID patients to this week was 50% non-COVID patients. So that would be heart attacks, that would be pneumonia, maybe a cancer patient, maybe a trauma, a gunshot wound or a car accident or things like that that need that high level of care. So when we put pressure on the system with our COVID patients, we're still seeing that pressure on the other side with those non-COVID patients. And all in all, we have patients to care for. So real quickly, I want to turn it over to Laura Auberly. She's our Director of Nursing at the Hiawatha Community Hospital. Hiawatha is up in Brown County along Highway 36 on the Nebraska line. It is a 25-bed critical access hospital that serves inpatient and outpatient. They do a variety of things. And so I want to let Laura talk about what she's seen this fall and most recently. So Laura?
Thank you, Sarah, and thank you everyone for the opportunity to join your call. Back in March, when we were anticipating the surge that we didn't get, we did go ahead and open up a COVID unit of 5 beds. So we are, as Sarah mentioned, a licensed 25-bed hospital, and our COVID unit has negative pressure rooms that we can take 5 or possibly up to 7 patients. We currently have 3 in that COVID unit, and then we have 2 COVID positive patients, which are on our skilled care unit. They're 10 days out from being COVID positive and have returned from a larger facility such as Stormont Vale or KU Med to recuperate. We currently have 11 patients in the hospital. So if you take those 5 patients, we're at a 45% positivity rate of the patients that are inpatients in our hospital. We have really seen a large amount of ERs. We're averaging on the weekends anywhere from 38 to 55 patients in the ER. And as Sarah mentioned, it's so important because people are still having heart attacks. We're still having traumas. And those are the areas that it's being a little bit difficult for us to transfer to. And I'll speak on that in just a little bit. One of the other things we did in March was we opened up a West clinic, which is kind of our respiratory clinic. And we had been consistently seeing maybe 10, 11 patients until about the middle of November. Around the 19th of November, we shot up to 29 patients. And that stayed consistency in the 20s. And then on November 30th, we saw an influx of 50 patients in that clinic in one day. We are just now dropping back into the lower 20s or below 20. At that same time in November, which was Thanksgiving, if you recall, we had 19 staff members out at one time. I'm happy to report today that we have 54 recovered staff and only 1 active case open at this time. We do have 9 openings for RNs. We are staffing with 3 travelers. We're looking to staff 5 travelers in January just to fill all of our needs. We have a lot of nurses pulling a lot of extra shifts just to keep this coverage going. We're so happy to report that we gave all 160 doses of the Pfizer vaccine we received last week, and it was definitely a shot of hope. You were very correct on that, both Jen and John. As far as testing, we are doing antigen testing in our West Clinic, and we can reflex that to PCR BioFire if we need to for an admission or if it's an employee. We are still sending a fair amount out to KDHE. All total, we've done around 3,500 tests here at Hiawatha. We are having trouble getting N95s. The small size N95s from 3M are at a premium right now. And we have contracted with Battelle Decon out of Oklahoma, and we are reusing our small N95s. They're cleaning them and sending them back to us. And probably our other big item that we're having trouble getting is extra large gowns. We seem to go through those a lot and have had difficulty getting those. And then as far as our transfers, it's really hit and miss. We've had weekends where probably our longest wait has been 7 hours for a cardiac bed. And literally we tried every hospital in the region, and several would say, can you give us 2 hours and we'll call you back? And that had kind of been our biggest challenge, more so early December and late November. Here lately, it's not been quite as bad. And I think that's also what has forced us to keep more patients in our COVID unit. We do have 2 ventilators if we need them. We haven't used them on a COVID patient yet. We also have a vapotherm, which is a high oxygen flow that we're using, a humidified oxygen, and we've used that a lot in our COVID unit. But all in all, I think December 22nd looks a whole lot better than November 22nd looked, but it's been quite a run this last month.
Thank you, Laura. We can't thank you enough for all the work you're doing on behalf of your community and in Kansas. And thanks for taking time. I know you have to be busy to take some time out of your schedule to come speak with us and into this region. It's helpful just to hear the realities of what's going on at all kind of levels of the care chain for folks inside of our healthcare system. So thank you, Laura, and happy holidays. Now, so you're talking about transfers, and that's, the several hours for a cardiac bed. You're not alone in that. Cheyenne Mountain Software and the Mission Control app, as it's called, has been trying to help with that. And he has some, Dr. Watson and Jesse here have some slides that they can pull up on a live dashboard just to help people see what's going on, to bring a little more color around that. So Dr. Watson, go ahead.
Yeah, Dr. Richard Watson practiced in the state of Kansas for a number of years, one of the founders of Cheyenne Mountain Software. And the software we're using, Mission Control, helps pull senders and receivers together, as well as transporters, so that we create a cohesive system. The state has asked us to help coordinate the placement of patients, particularly in the times where bed availability is at a premium. And we're working to make it available to every hospital in the state by the end of the year. So this is software that we've been using for a couple of years in the state, and we're actively engaging with both senders, receivers, and transport vendors. We look at a number of things just globally. Our picture becomes a much broader brushstroke. This is state data that we pull together in a kind of a reformatted look. Blue, obviously positive cases, reds, hospitalizations, and blacks are deaths. And I think we see what everybody is seeing, obviously, that we've reached sort of a peak, but more of a plateau. And everybody's interested in what the Christmas spike will bring, if there will be one. But I think the word here is that we're at a high level, and we're very comfortable with that being a high level, which is kind of disturbing on some levels, that we've grown used to this kind of picture, and even the little bit of breathing room we have hopefully is enough to give people a break, but hopefully not complacency. And that's the key. I think that's what we need is to make sure we all understand we're still there right now. And the next one shows when we do our bed availability, we do it differently than some of the other tools out there. We want to know, our hospitals at capacity? Are they close to capacity, or are they at normal capacity? And our job is to find beds. And so we are making the calls that typically small hospitals would have to make. I mean, we know there are places that have made 10, 15, 20 calls to find a bed. We certainly, on behalf of hospitals, are making anywhere from 20, 25, 30 calls to a 5-state region sometimes in order to secure placement. And I think really what what Sarah and Laura both said are very, very true, that this is labor-intensive work that's out there, and it's COVID and non-COVID patients, and oftentimes it's time-critical diagnosis where minutes do matter, and you have very sick people who are at places that obviously have limited resources. They don't have unlimited consultants. They don't have the ability to call the pulmonologist, and they're having to manage these patients in their emergency rooms for protracted periods of time. And our job to come alongside them, to take the burden of finding the transport, finding the bed availability. We also are working with them to help them manage the patient through consultation while they're having to care for this patient waiting for a transport. But out of that, we get statistics that help us make decisions about what's happening in the state. And I'm going to give you an example. Jesse will walk through this on a statewide basis. We'll have more regional data as time goes by. But Jesse, you want to walk through this?
Yeah, so this is a snapshot of the transfer data we have from the last 30 days. You'll see some high-level statistics here in terms of median acuity. At this point, we're just around 40% have been COVID presumed transfers, and globally 35% have needed assistance in locating a bed. What we do is help identify potential receivers and then allow both the sender and the receiver to connect for final acceptance. But that statistic is abnormal, obviously, that 35% would need assistance in locating a receiving facility. We have time metrics in this bottom left corner. This first median time metric is from when the transfer request hits our database to when a vendor or a transfer entity shows up on site. So you'll see that hour and 18 minutes. If we then select those that have requested assistance in finding a bed, you'll see we add over an hour to that time metric. And obviously that becomes very difficult for those time critical diagnosis. And those that need bed assistance, your COVID positive or COVID presumed rate on those transfers jumps over 60%. Furthermore, if we look at time critical diagnosis, it jumps. And then there's one here, and Dr. Watson, actually let's jump at, so if COVID false, time critical true, you can see then that we're at the hour mark. COVID false, though, you can also then see a significant delay on other working diagnosis that then would need to be transferred. And there's an example here out of Santana that is interesting. If we look at their need assistance with a bed, we had one of these non-COVID related patients that had a very protracted and prolonged wait period for that transfer to occur, indicative of the overall strain everyone's spoken to system-wide.
Yeah, and I think, I mean, if you go, most of the time it'll be a weekend, it seems like Thursday, Friday, Saturday, Sunday, where you'll see the bed availability dashboard go completely red, and you'll look at the board and understand that it's taking 20 and 30 calls to find a bed at that point, that people wait times are 2, 3, 4 hours to get to a referral center. And that the amount of angst that is happening with families and with the providers both definitely increasing. So I think even though we're what seems to be a plateau, and we're approaching Christmas, we're approaching New Year's, we have big gathering holidays ahead, I think the word here is please, please, please continue to do the things that protect everybody and keep everybody safe. And the vaccine's great. We know that's part of the long-term answer, but the short-term answer is to stay the course here and understand that particularly in these small communities, they are taking care of very, very sick patients who typically would be easy to move along. And now we know they're not as easy. So thanks to everyone who's working hard, Laura, certainly Sarah, everybody out there, Jen, we just really appreciate the work that's being done.
Thank you, Dr. Watson and Jesse. Before we wrap up, I'd ask the other participants, do you have anything that you'd want to add on top of what we just looked at? Laura, Sarah, or Jen, or anybody, anything you want to add before I wrap it up? All right, well, I think, we wanted to just help tell the story. I think most people can understand how it works, but when you get out into the more rural areas, there's not as just many tools to take care of acute patients, and that's not just the COVID patients, but that's all patients. And then they move up the chain into the regionals and then into the major metros where there's more tools and more expertise and available. And so why we're paying such close attention to the transfers is that's that process. And then as people get better, being able to transfer them back closer to home, as they recover, it's that movement back and forth, which typically is not an issue. And when Dr. Watson talks about us being at the edge, and we heard it in both the KC Metro and South Central region here, that we're close. And you saw how many reds were on that dashboard that Dr. Watson showed earlier. So there's times when it's just very, very difficult where you have a patient deteriorating in a hospital that could benefit from more expertise that's waiting for a room. And so that's why it's important that as we wait these coming months for the vaccine to be rolled out and all that we continue to make the choices as individuals, that impact our communities. This is just the reality of our healthcare system in Kansas right now. Wonderful people working, as you heard from Laura. You can just tell by her eyes, even above the mask, what a great caregiver she is. And Jen and Sarah for leaning in the ways you are. Dr. Watson, Jesse, thanks for the presentation. A bright spot, as we like to conclude with, catching people just doing something right as we all try and lean in. We have a group in Lawrence that's creating an outdoor socialization area for the winter, complete with a tent, heaters, making a safe and comfortable place for community members to socialize through the winter. Just knowing that people still want to touch base, but what are the safe ways to do that? So we just love these proactive groups. A lot of these stories are coming to us from the Kansas Leadership Center. We also have gotten some through the email address of ksregionalreport@gmail.com. If you want to highlight acts of kindness or generosity that are going on out there, we'd appreciate hearing that. Wish everybody happy holidays. Thank you. We'll be again at this same time every week here for the Northeast region at 2:00 every Tuesday. Thank you, everybody, for being on here today, and just wish you a wonderful holiday season. See you next week.